Uh, Hello everyone, this is the Shientist, and I'm going to give an overview of another important area, subject entity surrounding health, healthcare, and research. But this time, giving a perspective or an overview um, uh, on science with narrative and mechanistically evidencing. This is part of the Storm focus series and introducing the Shientist. And this is another a Storm Lobostics production. Um, to highlight initially, I'm going to give this overview in three segments as part of this overview on this particular topic. Um, I'm going to give a bit of a background or an introduction, and then linking an area of healthcare or a few areas of healthcare across across and in between healthcare sectors. Then a, a, a bit of understanding in relating to what's been highlighted in literature, so the crux, and then basically just a summary. And as with the previous audios or podcasts, I have highlighted some evidence in regard to the literature and how listeners can access um, uh, um, uh, papers and publications. Um, and in this with this overview, I would be doing the same, highlighting a few paper publications where listeners can hopefully identify resources or um, to uh, uh, help with areas of further further reading, and uh, uh, hopefully linking with um, uh, 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 further areas of practices where those are where the literature might be more specific to uh, the those who are listening, um, and areas where they would like to see uh, development, um, and a linking between uh, um, different aspects of healthcare, and um, uh, healthcare and potentially hopefully uh, uh, more empowerment overall. So a bit of background then to begin with. Uh, so in general healthcare, and where research is concerned and where science is concerned, clinical and medical interventions around different aspects of healthcare. And in one way, I want to use the terminology interventions quite loosely, but where interventions are implemented to improve aspects of patient care, or entities around patients' lives, then another way of putting this understanding forward would be is where I would like to highlight terminology that would be very familiar with healthcare professionals who are focusing in and around areas of research, and that terminology is a focus on clinical trials, where those who would be familiar with clinical trials would know there are 4 different phases in clinical trials. In this context, clinical and medical interventions put forward in line with specific clinical trials. These can cascade cascade or trigger more prominent methods for methods and modality for more evidence to be to be developed with and from researchers in science and healthcare after potentially an intervention or a focus has been successfully trialed. More evidencing around specific clinical trials and as part of the different parts of the different clinical trials, and where more evidence can be developed, that can provide and offer understanding of where best practices exist or have existed retrospectively in between healthcare sectors, as well as in health healthcare specialisms. In as much as clinical trials look to potentially either intervene or actually prompt novel efforts or novelty into aspects of healthcare. Care needs to be meticulously planned in and around different clinical trials how they are ensuring really there's clarity around the advantages and disadvantages of those of them. Sorry, and in this regard, trialists or clinical trialists should be aware, or I'm sure are aware, that in certain areas of healthcare or health research, therein lies opportunities for different patient cohorts to be part of those. And in this context, again, I want to give the focus, or keep the focus on chronic kidney disease or kidney care practices, and a focus on, for example, where in clinical trials, patients who may be receiving different forms of renal replacement therapy, and where, for example, different trials have retrospectively looked and seek to recruit patients for who might be on these different renal replacement modalities, for example, hemodialysis and peritoneal dialysis, for to see or identify if what is being clinically trialed actually has patient benefit, and in this way also there must be an understanding where patients who go through these different forms of renal replacement therapy do tend to endure quite a bit of health can have various health complications, but some and when I mean some, I mean those who are well versed and know how to take ownership of different aspects, so they ultimately can not just make important healthcare decisions, because actually to be blunt, it doesn't really take a genius to make important healthcare decisions. It just means that those who can make healthcare decisions tend to be a little bit more informed than the general public in some way or another. But in this context, I want to say that those patients, for example, who know how to, for example, navigate areas of healthcare and between healthcare sectors, and also know how to have dialogue and constructive communication with healthcare professionals, to the point where they are using their resources to evidence with what has traditionally made up part of the knowledge base contributing to to that specialty, for example. So there is an ongoing requirement and therefore to relate healthcare from guidance to patients, so that health professionals who want to keep informed can also link and achieve across several areas aligning to healthcare practice. And again, I give the example of those healthcare practices that surround nephrology, or the study of kidney care, or kidney care practices. So with that understanding, I also want to highlight that healthcare science and research entities that require further investigation, for example, in those who are post-transplant versus pre-transplant, there should be a premise to understand prevention and interventional focuses, and when healthcare generally involves context around intervention or intervening, that language is normally relating to normally healthcare professionals who have a focus around research would potentially know that there's a clinical trial that a patient could be recruited into that could ultimately be advantageous in and around the longitudinal aspects of their healthcare. And in that way, this one of the most common areas of clinical trials, not just in nephrology, but in and around other areas of healthcare, have tended to be, or have the tendency to be, and surround those around cardiology or cardiovascular health as well. So in that context, there's work by Dolgos and team in 2011, and again there is more recent literature as well, and I will highlight some more of the literature towards the end of this audio and podcast. And generally, where literature highlights context around specific areas of clinical trials and cardiovascular health or cardiology, tend to be focused around pharmaceutics and pharmacotherapy, and that's part and parcel of cardiology, perhaps more than any other healthcare specialty, but it must also be highlighted where intervention is concerned around that area of healthcare, that can also relate to interventions such as surgery or surgical interventions. So, for example, in clinical some clinical trials that have been evidenced and documented around cardiology or cardiovascular health have related to whether a particular form of treatment, i.e. A certain pharmacotherapy, would that be more advantageous in suspect or high risk patients for certain to prevent, for example, cardiovascular events versus those versus a surgical intervention, for example, to prevent myocardial infarction or ischemia, then there may well be an intervention, a surgical intervention that might well be more advantageous. But from the two, which is a clinical trial would look to document, which would potentially give individuals maximum benefit and on a longitudinal basis versus the short term. And by the way, listeners should seek to understand or to understand that short-term effects or short-term outcomes as part of clinical trials do also get documented, though those the short-term effects are not often shared with patients, whether a patient has been recruited into a clinical trial or which has also been a disadvantage because that also might lead patients into believing that generally they don't want to be part of clinical trials. They may have had a poor experience in regard to how trialists and clinical trials have been conducted. So here it's important to understand that as I give that example, pharmacotherapy solely to, for example, post-transplant patients versus pre-transplant patients, or even in the reverse, is also poignant understanding to have, and that in either of those examples, pharmacotherapy or pharmaceutics has been a dominant feature in health practices across several specialties, but also in the last I'd say in the last 7 to 10 years, so over a decade, perhaps, certain areas are have been impacted and so clinical trials that could be advantageous or beneficial to areas of healthcare, and of course research, where research is concerned and where patient benefit would ultimately be one of the outcomes. There has been some stagnation. Work around or research around linking areas of ischemia, myocardial infarction, cardiology, pharmacotherapy, and that particular area of healthcare has been published by Luco Georgiakakis and his team in 2005 and also in 2007, and I would encourage listeners to see if they can identify and access their the publications around that particular author. There's been some a lot of work around cardiology and cardiovascular health, and ischemia, and something that's referred to as remote ischemic preconditioning, dating back to 2000 and just before 2000 and just before 2009 and 2008, but and those were and those 2008 and 2009 and a little bit before actually were sort of kind of important time points, really, where there was actually quite a lot, quite a bit of effort made by different trialists around different pharmacotherapies in and around different areas, and collaboratively, quite rightly so. So so listeners are more than welcome to check out Luco Georgiakis and his work in 2005 and 2007, and there would be more work relating to ischemia and myocardial and prevention of myocardial events in the more recent years. I also want to read out this quote, and it's a direct quote from a paper by Ventura and Mira in 2005, and they say that more recently, clinical and epidemiological studies demonstrated that cardiac disease is a frequent complication, or can be a frequent complication in advanced chronic kidney disease, or in advanced kidney disease, and actually can be one of the major causes of death in patients on renal replacement therapy. And I think that's quite an important understanding to be had here, because at the same time, those who have been listening to some of the other podcasts, I have mentioned that the area of nephrology, both adult nephrology and pediatric nephrology, really, the specialism or specialty is still quite, has been a niche for a very long time. When talking about kidney care, it's not, or kidney care practice, it has been more about those who practice areas of practice healthcare and implement areas of their healthcare for patient benefit. Normally, it's professionals talking to professionals who are already within the field, and those who are perhaps training in areas of kidney care practices and nephrology. They see that there's a need, a requirement to be more collaborative, but we still don't see, or it's still kidney care practices still are not part of day to day in the public domain. So that being said, however, this is perhaps not too complex to understand, that and based on what Ventura and Mera said back in 2005, because of the function of the heart and what its role inevitably is about, in the short term, perhaps more than the longer term, effects can affect physiology linked directly to renal physiology, because both the heart and the kidneys, they have a link in regulation and monitoring of arterial blood pressure. So it shouldn't be a surprise really for listeners to understand or appreciate really that clinical and epidemiological studies demonstrate that that complication sort of coexists really with those who undertake renal replacement therapy. Now, just really the crux of this is that, and I'm focusing again more on nephrology or renal, or the renal specialism, and that is to say that the kidneys are small organs, and anatomically, all humans are born with two kidneys. They are, in comparison to other organs within the body, and as part of physiology, they are perhaps the more sensitive organs because of the multifunctional purpose that they serve. And then once, for example, a patient or an individual is diagnosed with a form of kidney disease, whether it's acute kidney injury or chronic kidney disease, in the longer term, acute kidney injury is irreversible to a point, but because the renal the kidneys have an inability to regenerate those functional components, i.e. the nephrons, the working components that actually help rid of toxins of the blood or of the blood through urine. There is this issue, and but also should come as a surprise that in the longer term, if that persists, that acute kidney injury persists, then chronic kidney disease becomes evident, and chronic kidney disease is irreversible. And I also want to highlight at this point that pediatrics versus adults would have there'd be different etiologies or pathologies as to why a patient might have or be diagnosed with a form of kidney disease. What the work that in some work that that also came out of Georgia Akis and their team was that they looked at apart from pharmacotherapy or pharmaceutics, they also looked at intervention by looking at endothelial function to identify myocardial occlusions, and they highlighted in their work, in their publications, that there are advantages, and obvious advantages to that is to actually help those clinicians who are practicing in cardiology and potentially in nephrology, if a patient has a risk or suspect or at risk of not just myocardial infarction, but at risk of having full-blown kidney disease as part of their diagnosis and follow-up. They could actually use the endothelial technique to actually measure and identify the extent of occlusions or ischemia. And so that can be helpful, and comprehension of certain disease markers as well, or biomarkers, can also be helpful, and there have been studies that are in and around biomarkers as well, and in that regard, there are patients who might find it more advantageous to be sort of linked into any potential clinical trial that looks to identify which biomarker could be more advantageous to excuse me, to screen patients, to screen patients who are suspect or high risk for chronic kidney disease at different time points, but if not at different time points, then in and around where these biomarkers might be more suitable across different age groups and populations and even ethnicity. Traditionally, there has been one biomarker that has been used and implemented for quite some time, and so whilst there have been advances made, and we know that it is known in these areas of healthcare and health research that clinical trials do have their place and advantage to identify which more areas of best practice across focuses that should and benefit patients. One clinical trials around biomarkers haven't really been center stage or focus where across areas across nephrology practice. So the science, what I want to say here is that as well that comprehension of or understanding both patients and professionals really should seek to get an understanding of these different biomarkers or disease and how they are relevant to disease, as well as linking an understanding of how they could that there is advantage or benefit by their implementation. So that being said, there is development of certain biomarkers to look for endothelial dysfunction as well, and that's important to have an understanding around, and different trialists or clinical trialists would look to seek to recruit patients into trials, into clinical trials, where wherever and that there is place and availability according to different regions and different risk populations, for example. But what I also want to highlight here is that it's important for people to get an understanding of what the clinical trials generally are about, and in linking in what I mentioned before about the clinical trials that look to prevent myocardial infarction or ischemia, the science linking cardiovascular complications pre versus post transplant is getting better. It's becoming smarter. However, more research is required on the prevention and implementation of biomarkers and their use to preclude cardiovascular disease. I also want to now highlight another quotation that's come from a paper by Wan and team in 2006. Again, a little bit of a dated a little bit dated context in some regard, but still very, very important to get to have this understanding. And again, I will highlight to listeners a few more references for further reading or referral for your own leisure. And that this quote reads as the following: age and sex adjusted cardiovascular risk is increased approximately 5-fold higher in post-transplant patients, and immunosuppressive agents or immunosuppressive protocols have revolutionized transplantation can have direct effects on cardiovascular risk factors and can contribute not only to premature cardiovascular disease, but also to the increased risk of malignant disease and death due to infection. Now, this is whilst it might be quite overwhelming for some listeners, this is again from a 2006 paper publication by Wan and team in 2006, and since then more has been done for the prevention of cardiovascular risks, and patients and professionals will know that there are efforts to ensure that patients have understanding about areas of healthcare and healthcare or healthcare management, and technology has paved the way for that in recent years. People generally are using, for example, apps through smartphone technology to organize and set out their healthcare, or at least have a way of linking that to their day-to-day. That all being said and highlighted, it's important to that the educational focus is also brought back into the areas of the mainstream, so that patients not just where they become more empowered, but where there may be difficulties in focusing around taking ownership, for example, by having access to timely educational support. That also has a role, and has focus. So it should be incumbent on both patients and professionals to have joined up thinking and mutual goals to bring that effort together as well. And I do believe there have been some clinical trials in and around areas of educational support, but there is not actually, for example, an educational pathway as part of healthcare, in nephrology, or actually in other areas of healthcare that patients can refer to or be aligned to, and that is something that still needs to be understood as a way of bringing best practice for patient care and professional involvement as well, to the point that best practice actually then becomes excellent practice. I now want to give a summary of this, and then and just a few references, and then I'll draw this to a close. So the summary around this is that prospectively there should be links to areas of science and medicine, bridging understanding of science and areas of healthcare across collaborative, and drawing in on collaborative efforts in different specialisms, so that evidence is part of a patient's care plan, a health care plan, and that should be actually routine, so that patients and professionals are again on a level playing field with regard to areas of practice more generally. So some references for further reading, and these are published works by several authors, some who I've highlighted as part of this audio or podcast, but there will be some other ones as well. So there's work by Cockwell Cockwell and Savage in 1997. So it's it is a little dated as well, but it's a very good starting point for those who might be intrigued by looking into how certain cell types are more prompted to bring about allograft or transplant rejection. This paper is titled Chemokines and Their Receptors in Leukocyte Trafficking and Renal Inflammation, and this was published in 1997 in Nephrology, Dialysis and Transplant. The paper by Dolgos and team in 2011, that's titled The Importance of Body Composition and Dry Weight Assessments in Patients with Chronic Kidney Disease, and that was published in a physiology journal. There's also a paper by Dolgos again before 2011. Dolgos and the team published a paper in 2008 looking at determinants of bone mass and end-stage renal failure in patients at the time of kidney transplantation, and also Dolgos also and the team and his team published a paper in 2009 looking at determinants of short-term changes in body composition following transplantation. I would like to recommend all three of those papers by Dolgos because they do bring together a focus on the more physiological aspects of healthcare. There's a paper that I really think was quite a good read with relating to pediatric nephrology, and this is a paper by Ferraris and his team and their team in 2006. Again, a little bit of a dated paper, but still quite an important focus around cardiovascular health, and this is a paper titled Potential Cardiovascular Risk Factors in Pediatric Renal Transplant Patients, and this was published in Pediatric Nephrology. Another paper more of a focus in line with the work that Cockwell and team followed up in 2000 and later, and it's kind of set the premise really for Cockwell's work in 2000, in post 1997, and this was a paper by Hancock and team in 2003, and the paper is titled Chemokines and Their Receptors as Markers of Allograft Rejection and Targets for Immunosuppression. So this is a paper that was published in Current Opinion in Immunology, and then it was in the paper by Inston and Cockwell in 2002 is also important. It's quite a good one, and that looks at the evolving role of chemokine receptors and their the evolving role of chemokines and their receptors in acute allograft rejection, and that was published in 2002 in Nephrology, Dialysis and Transplant. There's also a paper by Jardine, and this was published in Transplant International in 2005, and that was titled Assessing the Relative Risk of Cardiovascular Disease Among Renal Transplant Patients Receiving Tacrolimus or Cyclosporine. So that was almost an overview looking at areas where patients might have been receiving either cyclosporine as their mainstay immunosuppression therapy, or tacrolimus, and it was an overview paper, but a kind of a compare and contrast between the two mainstay immunosuppression therapies. There's also a paper by Jardine and colleagues, another one in 2005, when they looked at, where the team looked at cardiovascular risk and renal transplantation, post hoc analysis of the assessment of LESCO in renal transplantation, and that was actually published in the American Journal of Kidney Diseases, and this was where the Jardine look at work focusing on the ALERT study. There was also a paper that Jardine published in 2000 and their team published in 2011, looking at prevention of cardiovascular disease in adult recipients of kidney transplants, and that was published in the Lancet. There was the papers I want to highlight by Luko Georgakis, published in 2005. Luko Georgakis and their team in 2005 look at remote ischemic preconditioning, where remote ischemic preconditioning provides early and late protection against endothelial ischemia reperfusion in humans. Role of the autonomic nervous system, and that was published in a cardiology journal. And then Luko Georgakis also published a follow-up paper really in 2007, looking at transient limb ischemia, and how that induces remote preconditioning and remote post-conditioning in humans by the potassium adenosine triphosphate, or ATP, channel dependent mechanism, and that was published in a journal called Circulation. There was the papers I mentioned. I've taken quotes from the quotes that I've mentioned, or quotations, are dated in 2000 and in 2005 and 6. So the paper by Ventura and Mehra in 2005, that was a paper titled "Improvement of Health, a Heart Failure After Renal Transplantation: The Complex Maze of Cardio-Renal Interaction," and that was published in a cardiology journal. And then the paper by Wan and colleagues and team, in 2006 was Cardiovascular Disease Management and Renal Transplant Recipients, More or Less Treatment. They posed the question, more or less treatment, and that was published in Transplantation. And then there was a follow-up paper by Wan and their team in 2007, the cholesterol titled "The Cholesterol Paradox is Flawed. Cholesterol must be lowered in dialysis patients," and that was a seminal paper in a dialysis journal. Again, I want to just highlight that do feel free to follow up the work by Mohammed and team in 2014, where they highlight the work around the renal patient support group, supporting patients with chronic kidney disease through social media, and that was published in the Journal of Renal Care. Do feel free to check out that paper and any of these references. You do feel free to follow these up at your own leisure. There will be more on the I believe under the renal patient support group, they have a ResearchGate page which has various publications and evidence based efforts relating to kidney care practices and areas across science and nephrology and involvement. Do feel free to check out that work at your own leisure as well. I now want to draw this to a close. Thank you for listening to this audio podcast from myself, the Shientist, bringing an understanding around science with narrative, mechanistically evidencing. This is an audio or podcast under the Ztorm focus, introducing the Shientist, and this has been a Ztorm Lobostics production. Thank you for listening.